Okay, sir. Good morning, everyone. Today, my topic of discussion is chronic thromboembolic pulmonary artery hypertension, the evaluation of the disease spectrum, and pulmonary thromboendarterectomy. So, in this discussion, we'll cover the following topics. We'll cover the definition of the pulmonary hypertension and Cteph. We'll discuss about the pathophysiology and natural history of the disease. We'll discuss about the clinical features, investigation, different modalities of treatment, and some basic surgical steps of PT, along with the preoperative indications, perioperative care, and how to take care in the postoperative scenario. So, first, the definition of the pulmonary hypertension. Previously, the pulmonary hypertension, a mean pulmonary artery pressure value of more than 25 millimeter of mercury was referred to as pulmonary hypertension as assessed by right heart catheterization. It was decided in the WHO Geneva conference in 1973. After that, several world symposium for pulmonary hypertension was held, and then the latest world symposium for pulmonary hypertension was the sixth one, where the new hemodynamic threshold for pulmonary hypertension was redefined as mean pulmonary artery pressure more than 20 millimeter of mercury. In different clinical studies, it was seen that the population resting mean pressure of pulmonary artery is approximately 14 millimeter of mercury, and a value of 20 millimeter of mercury encompasses two standard deviation above the mean. A value of 20 millimeter of mercury is therefore definitely above the normal distribution of values, and by consensus correctly has been used to identify candidates for participation in the different clinical trials. Chronic thromboembolic pulmonary hypertension is a form of pre-capillary pulmonary hypertension that results from incomplete resolution of the thromboembolic material in the pulmonary arteries, which gets organized into fibrous tissue and results in vascular remodeling, which causes persistent elevation of the mean pulmonary artery pressure and also in elevation of the pulmonary vascular resistance. Now, let us discuss about the pathophysiology of the disease. Current knowledge suggests that two types of vascular lesions exist in Cteph. One is the proximal fibrotic obstruction in the large elastic pulmonary arteries and a secondary microvasculopathy in the pulmonary vessels. Origin of the most cases of unresolved pulmonary emboli is often from acute embolism. So in the flow chart we can see that the acute pulmonary embolism is the initiation of the event which is precipitated by pre-existing prothrombotic condition in the body. So origin of the most cases of the unresolved pulmonary emboli is often from acute embolism. The volume of acute embolic material may simply overwhelm the lytic mechanisms, leading to total occlusion of a major arterial branch, may prevent the lytic material from reaching and therefore preventing the dissolution of the embolus incompletely. So this partially or incomplete resolution of the thrombus, which indicates the failure of the fibrinolytic mechanisms of the body, may lead to the organization of the thrombus, and the organized obstructing thrombus may eventually lead to pulmonary hypertension. The organization of the clots proceeds to recanalization and canalization and producing multiple small endothelialized channels separated by fibrous septae. So in the right side of the diagram, we can show we can see the fate of the thrombus, which may either completely or partially occlude the pulmonary arteries and undergo different changes. It can form the webs or bands it can recanalize, and it can partially or completely occlude the pulmonary arteries. Complete fibrous organization of the fibrin clot without canalization may result in solid mass of the dense fibrous tissue totally obstructing the arterial wall. Natural history of the disease. So, most of the pulmonary hypertension leading to Cteph patients are asymptomatic initially for months to years, which making the Cteph a delayed noticeable disease. If we see the survival rate, the 5-year survival rate was 30% among those with mean pulmonary artery systolic pressure of more than 40 millimeter of mercury. Only 10% survival rate among those with mean pulmonary artery systolic pressure of more than 50 millimeter of mercury. Pulmonary department of the University of San Diego, the mean concluded that the worsening mean pulmonary artery systolic pressure more than 30 millimeter of mercury indicates poor prognosis without any surgical or medical intervention. Clinical manifestation. Presentation is usually asymptomatic, with minority of the patient presenting with history of deep venous thrombosis. Although in Indian population studies, as well as 40% of the Indian population may present with a prior history of DVT. The most common initial symptoms being the symptoms of the pulmonary hypertension, which includes exertional dyspnea or reduced exercise tolerance, chest pain, fatigue, and lightheadedness. Manifestation of the more advanced disease includes syncope, abdominal distension, and lower extremity edema, which are attributable to right ventricular failure. It is seen that delay in diagnosis occurs in around 20% of the patient. A delay in diagnosis was frequently observed in patients whose symptoms occurred at a younger age, that is less than 36 years, in those with the suffering from COPD or obstructive sleep apnea. It appears that the young people in whom the cardiorespiratory disease is considered less likely are the patients thought to have an alternative explanation for the symptoms are at most risk for the delayed diagnosis of this pulmonary hypertension. In some patients, the clinical presentation may be related to mechanical complication of pulmonary hypertension and the abnormal distribution of the blood flow in the pulmonary vascular blood. This includes hemoptysis related to rupture of the hypertrophied bronchial arteries, as well as the symptom attributable to pulmonary artery dilatation, such as hoarseness of the voice caused by the compression of the left recurrent laryngeal nerve, wheezing caused by the larger airway compression by the dilated pulmonary artery, angina due to the myocardial ischemia caused by the compression of the left main coronary artery. Significant dilatation of the PA may result in a rupture or dissection of the leading to the signs and symptoms of cardiac tamponade. Now the clinical findings. When we examine a patient of pulmonary hypertension, among the physical findings to suspect pulmonary hypertension in Cteph patient, we may find the accentuated pulmonary component of the AS2, which may be audible at the apex in more than 90% of the cases. Early systolic click or mid-systolic ejection murmur. These all are due to the high pulmonary pressure that increases the force of the pulmonary valve closure in the RBOT, and also the sudden, maybe due to the sudden interruption of the opening of the pulmonary valve into a high pressure artery. The last three signs are due to RB dysfunction and RB hypertrophy. We can find the left parasternal lift. We can find the right ventricular S4, and we can find the increased jugular A positive deflection due to the poor right ventricular function and compliance. In case of more advanced disease, when the disease progresses to moderate to severe pulmonary hypertension, we can find that holosystolic murmur of severe tricuspid regurgitation. We can find the increased jugular V wave, pulsatile river, diastolic murmur, or hepatojugular reflex, which all are attributable to increased RV dysfunction and RV failure. In the more advanced stage, in the severe pulmonary hypertension, we can find the right ventricular S3, which is the ventricular gallop. We can find the distension of the jugular veins, hepatomegaly, peripheral edema, ascites, or low cardiac output symptoms. These all are attributable to right ventricular failure and right side of the heart dysfunction. Inspiratory crackles are usually are usually absent. However, if present, they may point toward any other interstitial lung disease present. An accentuated pulmonary component of the second heart sound is present in almost patients with pulmonary arterial hypertension because of high pulmonary pressure, which is discussed earlier, which results in more forceful closure of the pulmonic valve. If a split S2 is audible at apex, the P2 may be accentuated and the possibility of pulmonary arterial hypertension should be further investigated. Now, a small discussion with the pathophysiological types of pulmonary hypertension. Pulmonary hypertension can be divided into pre-capillary, post-capillary, and combined pre- and post-capillary subtypes. Pre-capillary hypertension, which is defined as mean pulmonary artery pressure more than 25 millimeter of mercury with a pulmonary capillary OH pressure, that is PCWAP, that is an indicator of left side of the heart pressure of 15 millimeter of mercury or less, and pulmonary vascular resistance of more than 3 Woods unit. Where post capillary is present when the mean pulmonary artery pressure is 25 millimeter of mercury or more with a PCWP 15 millimeter of mercury or more. Now here the recent guidelines have updated the characterization of the post-capillary pulmonary hypertension and now rely on the new criteria, that is diastolic pressure gradient. That is the difference between the diastolic pulmonary artery pressure and the mean pulmonary capillary OH pressure. The difference is known as the diastolic pressure gradient. It is determined the presence of pulmonary vascular disease as opposed to the passive congestion in the left side of the heart. PCWP represents the LA pressure, which will rise in the cardiac causes, and that's why with the rise of the PCWP, this diastolic pressure gradient will fall. So, if the diastolic pressure gradient is less than 7 millimeter of mercury with a PVR of less than 3 Wood units, which reflects it is isolated post-capillary hypertension. Whereas a diastolic pressure gradient of more than 77 millimeter of mercury, that is the PCWP is less and PVR is more than 3 Wood units, it's considered as the combined post-capillary and pre-capillary hypertension. Now, how do we investigate for CTPH? The primary aim is to establish whether it is a pre-capillary or post-capillary primary pulmonary hypertension. That is, post-capillary means we have to rule out the left heart as the cause of pulmonary hypertension. Next is in the pre-capillary causes, whether it's a cardiac cause or to rule out the lung cause, as the lung pathology would be the next most common differential for pulmonary hypertension. Now, the basic preliminary investigation is two-dimensional echocardiogram. It is the first investigation which helps to diagnose the pulmonary hypertension while evaluating a patient who presents with the symptoms and signs related to the cardiac dyspnea or dysfunction. The 2D echocardiogram can assess the both pulmonary arterial hypertension and differentiate from the pulmonary venous hypertension. Echo has different indirect indicators to difference these both. However, the cath is needed for making a definitive diagnosis. We can, in the echo, we can assess the relative size of the left versus the right heart chambers. We can assess the E by A ratio, that is early diastolic filling and late diastolic filling ratio of the left ventricle. We can see the atrial septal bowing and to know the which side of the heart chambers are dilated. We can also, from echo, we can differentiate between the pre and post capillary uh, pulmonary hypertension. We can also evaluate the signs of elevated pulmonary vascular resistance. There are some indicator which indicates the rise in the pulmonary vascular resistance. These are all not definite, these are the indicators only, but the definite measurements obviously by the right heart catheterization. From the echo, we can know the severity of the disease also. We can know the RB, how the RB function is by measuring the TAP C. We can see any pericardial effusion or is there or not. So this is a table which comparing how we can differentiate by the various echo parameters, the pulmonary arterial hypertension and pulmonary venous hypertension. We can see the obviously the cardiac chamber size. In arterial hypertension, obviously the right ventricle, right side of the heart chambers are enlarged. In pulmonary venous hypertension, it may be normal or may be enlarged. On the left atrial size, obviously in case of pulmonary venous hypertension, it will be enlarged. We can see the interatrial septum, which is can be seen in the lower part of the image in both sides. The interatrial septum in case of pulmonary arterial hypertension goes from right to left, while in case of pulmonary venous hypertension, it goes from the left to right. We can compare the E by A ratio, that is early diastolic filling of ventricle in case of diastolic dysfunction. If in case of pulmonary arterial hypertension, it would be very much less than 1, while in case of venous hypertension, it will be more than 1. We can also see the aortic pressures, can estimate the pulmonary vascular resistance, and obviously we can this pulmonary capillary OH pressure will be less than 15 millimeter of mercury in arterial hypertension, while in venous hypertension it will be more than 15 millimeter of the mercury. In the echo, we can estimate the pulmonary artery systolic pressure. However, the pulmonary artery systolic pressure is not the criterion to define the pH, but it is important, a predictor of pH, and also useful in follow-up of the patients. Mean pulmonary artery pressure and diastolic PA pressure are not reliably recorded on echo and need cath confirmation. In parasternal long axis view, it is obtained the coaxial TR jet, and from this TR jet we can assess the pulmonary artery systolic pressure. The Vmax of the TR jet is used to in conjunction with the RA pressure to estimate the pulmonary artery systolic pressure, which is again an indirect measurement. We use the modified Bernoulli's equation to compute this pulmonary artery systolic pressure, which is equal to 4 TR Vmax square plus right atrial pressure, where TR Vmax is the peak TR velocity. So this from peak tricuspid regurgitant jet velocity along with the right atrial pressure, we can calculate the pulmonary artery systolic pressure, which might be a good indicator for follow-up and important predictor for the pulmonary hypertension. This right atrial pressure we can obtain from either from the collapsibility of the IVC or from the central venous pressure by the central cannula. How the RV looks on echo in case of pulmonary hypertension, there are various signs of the RV enlargement in apical 4-chamber view. These are the echo parameters which we look for the RV dysfunction. RV shares apex with the LV. RV is bigger than the LV or RV vessel diameter more than 42 millimeter. RV hypertrophy in subcostal view with a RV end-diastolic wall thickness more than 5 millimeter. RV systolic dysfunction, that is RV fractional area change less than 35%. The TAPSI is less than 16 millimeter. RV tissue Doppler velocity less than 10 centimeter per second at the base of the RV free wall, that is around tricuspid annulus. In case of systole, septal flattening of the RV denotes pressure overload, or in case of diastole, the septal flattening may indicate the RV volume overload. High pulmonary vascular resistance on echo. So we know the pulmonary vasculature is a low resistance and highly compliant vessel. So normal pulmonary vasculature with high compliance produce a reflected wave that propagates slowly, reaching the RVOT after the completion of the systolic phase. So this phenomenon indicates the pulmonary vascular resistance on 2D echo. In the presence of decreased pulmonary vascular compliance, the reflected waves propagates more rapidly with less attenuation, arriving at the RVOT during systole and causing mild systolic notching. This is the diagram showing this phenomenon. While in the first diagram, there is no notching, while in second diagram, mid-systolic notch is present, followed by a second acceleration, which indicates that their PVR resistance is high, but still RV function is preserved. While the last diagram showing there is no acceleration after the mid-systolic notch. So, resistance is high, but this RV is now not coping up with the pressure. So, thus with this phenomenon, we can assess the pulmonary vascular resistance from 2D echo. Now what? Till now, from the clinical findings and the basic investigation echo, we have reached to a point that we have a definite evaluation of the heart. We know the status of the LV and also the RV, and can surmise whether or not the left heart is responsible for the patient's pulmonary hypertension. Now we are looking for a definitive diagnosis whether the pulmonary arterial hypertension is pre-capillary or post-capillary. For that, we require further evaluation. We require the right heart catheterization. Along with this, we also need to evaluate the lungs, as the lungs is the second most common pathology. So we will proceed with some ventilation perfusion scan and also the CT scan as the next. So right heart catheterization. Invasive hemodynamic assessment by the right heart catheterization is a pivotal in the evaluation of any patient with suspected pulmonary artery hypertension. Right heart catheterization is typically performed after the non-invasive testing for pulmonary hypertension described earlier. However, some patients initially suspected of having pulmonary arterial hypertension will not require right heart cath because they have had an alternative diagnosis established by non-invasive testing. However, all the patients who are still suspected of having pulmonary arterial hypertension after non-invasive evaluation must undergo right heart cath before any initiation of any definitive therapy. Now, the measurements we usually take during right heart catheterization, we will obviously see the oxygen saturation in all the chambers of the heart in SVC, IVC, and pulmonary and systemic arteries. We will see the right atrial pressure, ventricular pressure, pulmonary artery pressure. In the left side of heart, we can measure the left heart sided filling pressure, wedge pressure, left atrial pressure, or left ventricular and diastolic pressure, LVEDP. We will measure the cardiac output and indexed cardiac output. We can measure the pulmonary vascular resistance. with this we can correlate with the systemic blood pressure and heart rate. We will also see the response of the to the any acute vasodilators. So this slide represent various CAT data, the graphical representation of the pre-capillary hypertension, uh, post-capillary hypertension, and combined pre and post-capillary hypertension. In the the most left part, we can see the pre-capillary hypertension with pulmonary capillary OH pressure of lower values with the PA pressure trace we can see. In the most right side, we can see an elevated pulmonary capillary OH pressure, which is a post-capillary pulmonary hypertension. And the middle one, we can see the combined pre and post-capillary hypertension. Here, the previously discussed diastolic pressure gradient is to be appreciated to differentiate the combined variety and post-capillary variety. Now the same thing we discussed, just given in tabular form. In pre-capillary pulmonary hypertension, obviously mean pressure will be more than 25 and OH pressure of less than 15 millimeter of mercury. The various clinical groups comes in this. The primary pulmonary arterial hypertension or pulmonary hypertension due to lung disease, chronic thromboembolic pulmonary hypertension, pulmonary hypertension with other unclear or multifactorial mechanism. While in post-capillary hypertension, that means the OH pressure is more than 15 millimeter of mercury. It occurs due to the left heart disease with some unclear or multifactorial mechanism. This post-capillary is further divided into isolated post-capillary pulmonary hypertension, where the diastolic pressure gradient plays a role, where the pulmonary vascular resistance is less than 3 Woods unit, or the combined variety where the pulmonary vascular resistance is more than 3 Woods units. So up to this, we have established whether the patient has pre-capillary or the post-capillary pulmonary arterial hypertension. Now we can go ahead with the diagnosis of the pre-capillary pulmonary hypertension. So next is, there are two possible pathologies. One is the pulmonary arteries, or pathology may lie in the lungs. Now we'll further investigate. We can basically do a pulmonary function test, which for evaluation of the any coexisting parenchymal lung disease or airflow obstruction. Approximately 20% of the Cteph patients with parenchymal scarring from the prior lung infection, a mild to moderate restrictive defect may be detected. Furthermore, Cteph patients will exhibit more hypoxemia and elevated dead space, which increases with exertion. Marked hypoxemia at rest may signify severe RB dysfunction also. Now, the next important test is the ventilation perfusion scanning. It is a valuable screening stressed in detection of the CTEPH and most importantly for exclusion of the CTEPH. It shows as 97.4% of sensitivity in detection, evidenced by a study in the Hammersmith Hospital, London. Essentially, if the ventilation perfusion scan is normal, then the diagnosis of Cteph can be excluded. Now, the most common gas used is xenon for ventilation scanning, while technetium 99 aggregated albumin is the radiopharmaceutical for used to perform the most perfusion lung scans. Normal ventilation scans, which have homogeneous material distribution throughout all lung fields on all three phases of the scan: initial breath, equilibrium, and washout phase. A subtle base to apex gradient may be seen normally also. Normal half time for xenon washout is less than 1 minute. Washout is complete within 3 minutes. Retention or trapping of xenon in the lungs in a focal or in a diffuse pattern is an indication of the obstructive lung disease. So these scans show well-defined margins of both lungs on all views with sharply defined costophrenic angles. A mild base to apex count activity gradient is present due to the physical difference in lung thickness of the base compared to the apex. Tracer distribution should be otherwise be homogeneous. So this is the normal ventilation perfusion scan. Shows a homogeneous distribution of the radioactive materials. Now, the ventilation perfusion scan in case of pulmonary embolism may show, as the diagram showing, different segmental defects. We can assess the defect size, site of the occlusion of the pulmonary artery. But however, the ventilation perfusion scan cannot differentiate the acute and chronic form of pulmonary embolism. A normal VYQ scan, which you can see by the 6 different projections, the normal ventilation and normal perfusion. While in case of pathologies, it might be ventilation perfusion matched or ventilation perfusion mismatched. So matched means the perfusion defect is consistent with the ventilation defects, which may be due to the any arterial disease, which might be due to any lung parenchymal disease. While the V by Q mismatch, that is the segmental perfusion defects, are inconsistent with ventilation scan findings. That indicates a diagnosis of chronic thromboembolic pulmonary hypertension or the pulmonary thromboembolism. As of now, we have reached to the point that we are dealing with a case of pulmonary thromboembolism. However, now the next question comes is how to differentiate between the acute form of thromboembolism or the chronic form of thromboembolism. For that, next step is doing a CT scan, CT pulmonary angiography, or going for the histopathology of the lesions. In CT pulmonary angiography, the signs of Cteph on CT pulmonary angiography, in the PA we can find the dilatation of the central proximal pulmonary arteries. PF diameter is more than 29 millimeter, that is 3 centimeter or more. We can find the eccentrically organized thrombus with eccentric intraluminar filling defects adherent to the pulmonary arterial wall. We can find the occluded pulmonary artery, the total occlusion defects or partial occlusions. We can find the irregularity in the vessel caliber, intraluminal fibrous bands or Oyabo bands seen as the ribbon-like structure anchored to the vessel wall as linear intraluminal filling defects. We can find also in the heart, we obviously will see the enlargement of the right ventricle with thickening of the RV right ventricular wall. We can see the multiple coronary or mediastinal collaterals. While in lung, we will find the mosaic perfusion pattern of the lung parenchyma along with the residual scars of the previous infarct. We can find some large bronchial artery collaterals. This is some CT images which showing the pulmonary artery thrombus of different form. We can see the vessel wall irregularity. We can see the outpouching of the thrombus. We can see the complete and partial occlusion of the pulmonary arteries in different slides. How to differentiate from acute and chronic embolus in CT? In acute, from inside out, it shows the filling defect within the pulmonary vasculature with acute pulmonary emboli. When the artery is viewed in its axial plane in the CT, the central filling defect from the thrombus is surrounded by a thin rim of contrast, which has been popularly called as polo mint sign. While in case of chronic, we'll see the webs or bands. We can see the intimal irregularities of the pulmonary artery. We can trace the pulmonary artery and search for any abrupt narrowing or complete obstruction of the pulmonary artery. We can see the pouching defects, which are defined as the chronic thromboembolism organized in a concave shape that points toward the basal lumen. Other indirect signs may indicate the chronic changes in the CT, which is mosaic perfusion of the lung fields, vascular calcification, bronchial or systemic collateral presence may indicate this chronic uh, thing. This is the slide showing the mosaic perfusion, axial, that is left side, and coronal high resolution CT slides demonstrating the mosaic perfusion. On the coronal view, we can see that the large Y-shaped perfusion defects in the right lung and the total absence of the perfusion segments. Now, multi-detector CT showing the intravascular filling defect in left lower pulmonary artery. Now, in case of CT pulmonary angiography, this picture is showing the partly and completely occluded pulmonary vessel. Sorry, sir. So this is yes, CT and angio image or showing the various webs and bands form as described earlier. So in this slide, we can see the webs and bands which are formed by the organized and recanalized thrombus. Webs are the bands are the delicate thread-like structure or ribbon-like structure of fibrous consistence covered by the endothelium and anchored to the intima of the pulmonary artery vessels. Now, and webs are the bands themselves which are branched and formed a network of variable complexity. So this left side is showing this branching webs, and the right side we can see the bands are like the circumferential constriction in the pulmonary arteries. So finally, we can arrive in a diagnosis of the Cteph, which as the Cteph requires the more than 3 months of effective anticoagulation and mean pulmonary artery pressure more than 20 millimeter of mercury with pulmonary capillary wedge pressure less than 5 millimeter of mercury and at least one segmental perfusion defect. Preoperative lab investigations. Before proceeding further, we have to see some normal preoperative blood investigation. We'll go for complete blood count. We'll obviously see the liver function test, kidney function test. We'll see the coagulation profile, blood grouping and cross matching. We'll see the thyroid profile. Various prothrombotic panel we'll see. Mostly antiphospholipid antibody, antithrombin 3, the protein C and protein S deficiency should be evaluated, factor 2 or prothrombin and factor 5 Leiden mutations we have to see. These all have increased the risk of thrombosis, and this prothrombotic condition in the body must warrant the chronic anticoagulation. We'll see the direct cum test and heat antibody screening test. Various clinical trial data published convey that around 21% of the Cteph patients have APLA positivity, while the 41% have increased factor 8 levels in blood. Modalities for treatment of Cteph. Three main modalities of treatment for Cteph. is one is obviously pulmonary thromboangioectomy, which is the single most curative treatment for Cteph. Balloon angioplasty of pulmonary artery. These are confined to the
Rajdeep,
disease.
sorry, can I interrupt? I think
Yes,
there is lot of things to discuss in investigations alone,
yes,
and
sir.
it will become too much thing.
Yes, sir.
Can it be done in two parts?
Yes, sir. Sure, sir.
Only if Dr. Sri Krishna and Dr. Jairaj think it's
Uh, sir, should I continue or?
because I wanted to talk. I mean, he's covered all invasive catheterization, and he's covered CT, and he's covered. I
Yeah,
just wanted to talk more about.
yeah. Varun, I also think that there is a lot of mix up between the various thresholds which is mentioned.
Yeah.
And
Yes.
so
Yes.
that needs to be clarified for the rest of
Clarified
them.
before he. Yes.
Yeah, and there are lots of, I mean, overall it's a nice presentation, but it's just there are lots of holes in it. So
Yeah.
we just need to clarify those. Otherwise, people will go back with completely confused ideas.
Yeah.
So
So I thought
if you
he
want to
could
do a
stop that.
second session, yeah, that's fine.
Yeah.
And is there a time restriction on it now?
Yes, sir. Okay, sir. And if Sri Krishna sir agrees, we'll continue the treatment modalities in the next class. We can
Maybe
discuss the.
Rajdeep, maybe you can coordinate with either Varun or Julius and show them your presentation, and then sort of streamline your presentation and come back again. That is fine, perfectly all right. What do you say, sir?
Yeah.
Jairaj?
Yeah. I think anytime somebody is calling another person for a presentation to be present, it's good to show the slides to that person beforehand. See, if you just tell us in the evening, there is no time to review the slides.
Yeah, that is precisely the reason why I wanted, at each time the practicing consultants to be on board so that they will give their inputs. And then we also learn from that what are the latest things that are being done in this process. So that is why when they are presenting a pediatric case or a pediatric topic, I wanted that pediatric surgeons to be involved, especially here, Cteph for aortic aneurysm, you or Varun should be around, and things like that. It becomes a little more interactive session and a proper learning. Otherwise, they will just read from a book. It's good.
Yeah.
So what shall
So
we do now? Do we discuss this or not discuss this?
no,
I
maybe
think.
as both of you have said that since there are a lot of controversies still to be sorted out, let Rajdeep sit with you people, one either you or Varun, and then come back with another presentation. Is that okay?
But I think we should just clarify all the mistakes which are there in this
Right.
so far.
So far you can do that. You say about you can tell us that. Yes,
And
fine.
we haven't gone to treatment, but before that, Varun, you
Sure.
want to go first?
Sure.
Yeah. Raji, few things. Can you go to that catheterization slide?
Yes, sir.
Invasive hemodynamic monitoring. You can see on your slide sorter and you can find it directly.
We just somebody is taking control of the slides and just.
Oh, okay. It's back. 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 Just one slide back. Yeah. Yeah. So just to start off with that, the next slide.
Yes, sir. Yes, sir.
Yeah. Uh, to see, right heart catheterization is not. There was something. However, all patients who are suspected of having PH after non-invasive should, I mean, not require right heart catheterization because they have an alternative diagnosis established by non-invasive testing. That is not completely true. The diagnosis of pulmonary hypertension, if you are making a see, if you want to get into the etiology of pulmonary hypertension, imaging is fine, CT or other non-invasive methods. But if you have to completely work up this patient, invasive hemodynamic assessment is extremely, extremely important. And so every patient, if you are diagnosing pulmonary hypertension and you are labeling them as Cteph, they need to undergo right heart catheterization. So it is not, there is nothing like will not require unless the clinical condition does not allow it. They have to have a right heart catheterization because unless you are able to measure the pulmonary artery pressure before, you're not able to establish a diagnosis. You're not able to establish the degree of pulmonary hypertension, and this is an important benchmark after surgery as well to measure to do. I mean, for you to see improvement as well. Okay, so invasive heart catheterization is extremely important because there are some patients who have what is called CTED. They have chronic thromboembolic disease and they don't have
Mm.
pulmonary hypertension. So you may have extensive disease on the CTPA, but when you do the invasive pressure monitoring, they're almost normal. Okay, so both nowadays both do require surgery, but it's extremely important to evaluate the two. Now coming to wedge, there is a technical problem in doing wedge because you have to take the unobstructed pulmonary artery. And unless you do, if you have patient who has complete occlusion, like level 1, lobar involvement, you may not be possible. So another surrogate for using instead of wedge would be doing an LVEDP, taking an LV shoot, measuring the instead of wedge pressure, you can measure the LVEDP, and from then on you can calculate. Then there's something called total pulmonary vascular resistance, which includes LVEDP in its calculation. So these are other alternative ways when you cannot do a wedge, right? Okay.
Yes, sir.
Then yeah, I think Dr. Julius would like to add some more on right heart catheter.
I have lots of other things also to say. So whatever you want to add to other things, please go ahead.
Yeah. Coming to VQ scan. VQ scan is an excellent screening tool, but if you look at the way we do it in our hospital, we don't use radioactive xenon. We do a plain CT. We look at air trapping or on the CT itself, and then we give the radioactive albumin. Now, it is an excellent screening tool, but what we have found out in our follow-up is it is not a good tool for seeing success. Initially, we thought it was the least invasive method to see if the patient has responded following PTE, but we find that even with the VQ scan, there are a lot of perfusion defects that happen after surgery as well. But when we re-imaged them with CTPA, we found they have established flow, but continue to have perfusion defects. So I don't know about its sensitivity in post PT. I can only vouch for its sensitivity in screening, but as a tool for follow-up and to see response to treatment, I'm not sure. I think there is a nowadays with CT you can do nowadays with modern CT scans you can do VQ on the CT image itself and establish. So for follow-up, I would stick to either imaging with CT pulmonary angiography or invasive hemodynamic monitoring, depending on what outcome you're looking to measure. Thanks.
So in continuation with what Varun's saying now, see, many of the investigations were dictated by the older CTEF centers like San Diego and Papworth, which Papworth followed San Diego. And in San Diego, they always do an angiogram. And they've been doing that same thing for a long time. And like in many old centers with good outcomes, they don't make any changes to their system. So another thing in San Diego, they don't have a lot of follow-up because they get patients from all over the place. So people never really come back there for follow-up. So their follow-up is also just as good as ours. They do a CT after so they do a VQ after the procedure, but most of them will still have some perfusion defects. But the importance of doing that is if you come back with pulmonary hypertension later, then you can compare it with your post-op CT. Not that it is diagnostic at that post-op point of time, but certainly Cteph is a good screening tool to either diagnose or rule out the disease. So, Varun, anything else you want to add?
No, sir, just these 2 points I wanted to add on to.
Okay. So, I have a whole lot of things to tell you. One is the nomenclature for this disease has been altered in the last couple of years. It is called CTEPD with pulmonary hypertension, which is also continued to be called Cteph, and there is CTEPD without pulmonary hypertension. So that is essentially the way it has been classified. In your presentation, you were mixing up pulmonary hypertension with Cteph. See, the way I would have gone about it is I would have mentioned how pulmonary hypertension is diagnosed and how pulmonary hypertension is classified, which you haven't mentioned anything about, and then would have just stuck to the precapillary pulmonary hypertension and went on to talk about Cteph. But in general, you had mixed up between all these throughout. The next point is about the diastolic pressure gradient. See, when you look at the various world symposiums on pulmonary hypertension, which has happened over the years, like you mentioned about the Geneva meeting. After Geneva was Dana Point, and then after Dana Point, there's been a series of meetings in Nice, and the last one was the 7th symposium, which happened last July in Barcelona. The findings of which has just been published recently, which I'm sorry, I have not read myself, so I do not know if there is a lot of difference other than the fact there is a lot of patient advocacy which has been included in that. So in the 5th symposium on pulmonary hypertension, which happened in Nice in 2013, the findings of that were published in JAC of 2013 November. John Luck had mentioned in great detail the diastolic pressure difference or a diastolic pressure gradient, but that is purely in relation to group 2 pulmonary hypertension. So the diastolic pressure difference is not a metric which is used in Cteph. So he went on to tell the advantages of the diastolic pressure difference, but yes, in the following symposium, which is the 6th symposium, John Luck himself has written or led the task force on group 2, where they have removed DPG as a metric. Because worldwide, there is, as Varun had mentioned, there is a lot of difficulty measuring the wedge pressure. If you look at our own cath lab, the wedge pressure measurements is most of the times wrong, because ideally to measure the wedge pressure, you must have a vessel wedged properly. You should be able to see the wedge waveform, and you should take a sample from the wedged pulmonary artery catheter, and that should show arterial saturation. That should be above 93 saturation. Only then a wedge is actually valid. People don't even zero the transducer properly, so invariably the wedge pressure becomes wrong, and a lot of times you get a diastolic pressure gradient which is negative, which led to removal of this as a metric completely. So we do not use that metric anymore after the 2018 World Symposium, which happened in Nice in 2018. That's the 6th one. Okay, so another thing is the thresholds have completely changed you mentioned it once, but there has been a lot of mix-up. Can I show you, if I can share my screen, I'll show you the current one.
Yes, sir. Please, sir.
Are you seeing my screen?
Yes, sir.
Okay, so the 2022 pulmonary hypertension guidelines showed that this is the current definition for all the different. Anyway, it's not relevant in Cteph. Since you were bringing it up, I thought I should show you this, because
Yes.
now PVR has been added as a metric. PVR was kept at 2 for the threshold earlier. Now, since 2022, it's been reduced. Sorry, it was 3 earlier. Now it has been reduced to 2. Okay, so we have to have all these which are shown here. That is the mean PA pressure of. You have to have mean PA pressure of more than 20 to call pulmonary hypertension. In pre-capillary, you have the difference is that the PVR will be less than 2. Your in post-capillary, the wedge will be more than 15 and PVR will be less than 2 in isolated post-capillary. In combined post-capillary and pre-capillary, you will have more than 2 PVR. So PVR becomes a very important metric in differentiating these. But again, I tell you, this is not very relevant in Cteph. This is mostly to do with left heart disease. That is where this whole classification comes in. Okay, I can stop sharing. So another thing is in your slide number 25.
Yes,
Can you put up your presentation?
yes, sir.
I'm not seeing that. Anyway, in slide number 20, yeah, now it's coming. So you spoke about vasodilator test. Vasodilator test is not relevant for Cteph at all. The only place vasodilator test is relevant is in group 1 pulmonary hypertension. And it is relevant to know if calcium channel blocker monotherapy can be used in treatment of group 1 pulmonary hypertension. That is why vasodilator test is used. There is a sit-borne criteria to see if vasodilator challenge is positive or negative. Again, I don't want to mix up things. This is not relevant in this. And we spoke about the threshold, which is outdated. And in slide number 30, you speak about VQ scan. And Varun had mentioned that we don't use ventilation, and no unit in and around us use the gas-based isotope because they are very short lasting. So you really cannot get this xenon and bring it up to, by the time it gets to our hospital, the xenon would have disappeared. It's a very short half-life isotope. So we use ventilation as a surrogate. That's the same thing which most organizations do. That is second part. And now SPECT has sort of superseded VQ scan as this mode. And again, as Varun mentioned before, dual energy CT is becoming something which we all rely on much more in terms of determining the perfusion defect. VQ scan or SPECT is a good way of screening a patient. See, suppose you find somebody with pulmonary hypertension when you do echo. And in investigating the cause of pulmonary hypertension, you have to rule out VQ scan, rule out Cteph by doing a VQ scan. That is the main relevance of VQ scan. If it is positive, then we go on to investigate them from the point of view of having Cteph. Can you show that number 40, slide number 40?
Yes, sir.
Okay. Another important thing to note here, there are large areas of vessels not being seen. So what is seen also is important. What is not seen is also important. So can you see that in the lateral part of the middle portion, you have an obstructed vessel and there is no perfusion there on the CT. There is lack of any dye going there. So this is an important observation when you look at the angiogram.
Yes, sir.
Okay, so I think that's probably all I have to say.
Yeah.
The thing is,
Just
you
to add
need
on,
to, yeah,
sorry.
you need to be very clear about pulmonary. I mean, it is not easy for somebody who is looking at it for the first time, but pulmonary hypertension is not one entity, and there are you have to learn the classification right from historical classification which Paul Wood used, right down to what is there in the sixth is what I can tell, because seventh I have also not seen what it is because I can't find it yet. So you have to differentiate between these things and how each one is measured and subclassified. Okay, don't mix up between all these things. And Cteph
Yes,
is a completely different entity. Those which go with Cteph are the ones which have got pulmonary artery occlusion by tumor, parasites, etc. Those are the only things which come. It's all luminal obstruction. The other things are different, so you mustn't mix up between these two. There are some common features which are limited to definitions of pulmonary hypertension, but all the others are different for different subtypes. I hope I was clear. Varun wanted to say something.
Yeah. See, if you look at this particular pulmonary angiogram, one important thing to note is, see, there are many advocates like us who believe that CT pulmonary angiography is sufficient because you will get a lot more information. You will get the nature of the lung parenchyma. You will understand the the anatomy of the heart very well. You can look for collaterals, like you said, which are an indirect evidence of Cteph. But remember, in a CT pulmonary angiography, you give the dye into the veins. That blood has to circulate throughout the pulmonary circulation, and you have to time it accordingly. It is whereas in a pulmonary angiogram, you're using a pressure injector, and to there are certain areas, there are certain situations, especially in subsegmental disease, which you may not be able to see as well on CT as you would be able to see on a pulmonary angiogram. So there are advantages to doing CT pulmonary angiogram only, and there are advantages to doing pulmonary angiography only. But in our context, to do both in every patient is not feasible. So what we do is we reserve it for some patients who have disproportionate pulmonary hypertension. Oh, you have but there's not enough representation of that disease on CT. Then we go in for a pulmonary angiography to see that extent of distal involvement, and that's the value of adding pulmonary angiography for us.
Along the same line, the when you do a CT, when someone has got only very distal disease, as you would see in this area where there are no vessels, CT could look normal entirely. And
Yeah.
cone beam CT is another technique which has been described to show you distal disease. Of course, pulmonary angiogram is still considered gold standard, and even better than that is the DSA, arterial DSA of the pulmonary. That gives you very good detailing of the pulmonary artery tree with selective
Like this,
injections. Yeah,
like this.
correct. This is a DSA.
DSA. Yeah. But I guess from a catheter, if you are planning catheter-based intervention to treat pulmonary hypertension, the pulmonary angiography becomes even more important. It's a roadmap. So in balloon pulmonary angioplasty and other interventions, if you uh, think so, what in our practice, what we do is if we are happy with the CT angiography findings, we don't go ahead with the pulmonary angiogram. Only if there is some doubt, then we would subject to thing. But there are many centers who go exclusively with pulmonary angiography and don't put so much weightage on CT.
Yeah,
Yeah.
this comes to the point that saying that, the difference between a CT and a angiogram is a dynamic study, which also tells you a real-time flow pattern of the blood through the vessels. Whereas the CT is a fixed image, and you can make different uh, problems that can be seen. The flow pattern differs in many times, and a still image can have a better this thing to delineate the anatomy.
See, the CT has a lot of advantages over the angiogram, pulmonary angiogram in this particular instance, because CT gives you a much better idea about collaterals. CT gives you much better idea about the parenchyma of the lung. And of course, we can do a CT coronary angiogram at the same time. So if you have to choose between pulmonary angiogram and CT, and we can do only one investigation, most of us would go for CT today, except San Diego. San Diego would still choose to do a pulmonary angiogram.
Okay. Thanks very much, Julius and Varun, for your inputs. I think it is a very important thing that the people should discuss these presentations with you people. I've been saying this for a long time. I'm sure Dr. Jairaj will agree as well. And that is why we wanted you people to come and then take part in our seminars whenever you're free, so that you can give a better input for the students. Thank you very much.
If we had seen these earlier, all these mistakes could have been avoided.
Correct. Exactly. They should. In very often they tell us the topic also in the last minute, the previous evening. So I think there should be some amount of change in the pattern, and then they should come and talk to you much earlier, and then sort out their presentations better.
But I want to congratulate Rajdeep on his comprehensiveness.
Correct.
He has done a very detailed and comprehensive. He's not left any.
It's a very practical approach presentation, which is very good. And then you can improve on that, adding the latest later techniques and later investigations that are being done, and also probably use our own assessment, what we do in our own institution.
It's okay, because see, pH is a very medical thing. So many people in surgery side will not know all the nitty-gritty of this, because Varun and I have been involved with pH. That's why the very reason is, when we make presentation on Cteph, lots of people will be asking questions about pH and acute PE, etc. So if you don't know these things, you look like a fool if you're standing there. That is the reason we all know. Otherwise, pH is very much medical, and all the guidelines are from the medical side. Everything about this is published in pH on medical journals, not in surgical journals.
Any comments, sir? Jairaj, sir?
My only comment is that you should have started with the international classification for types of pulmonary hypertension. Type 1, type 2 with left heart disease, type 3 with lung problems, and type 4 becomes a Cteph, That's one thing. The other thing is, as both of these experts pointed out, that the wedge pressure can be very misleading. So from time immemorial, we used to say that it's properly wedged, then you should get the tracing of the LA, and you should get a LA saturation, then only the wedge is actually correct, So that's a main comment I've got.
Yeah, they take only 5 minutes to do a right heart cath, because they want to do angioplasties after that.
Exactly.
You don't get much information from those.
True. So maybe, as both of you have said, maybe we should start having a seminar on just pulmonary artery hypertension, and then go on to chronic thromboembolic pulmonary hypertension. What do you think?
You should get the medical folks also involved. We have a good pH center. So Dr. Murali and Dr. Basha and all have got a lot of expertise on the medical side of pH. So I think Dr. Murali is considered one of the city's experts on pulmonary hypertension. Even other pulmonologists send patients to him. So we should utilize his expertise also.
So the next person who is going to be presenting the seminar, Karan can decide that. Karan, I'm not sure whether he's there. The
Yes, sir.
next person should go and meet Murli and then get hold of a time with him and then do a proper presentation on pulmonary hypertension, and then we come back to this topic again. What do you think?
Basha also.
Yeah, Basha or Murli, whatever. Whoever is free.
Okay, sir.
Yeah, you do that.
Yeah.
Okay. Thank you very much
Uh-huh.
for joining
Thank you,
us.
sir.
And thank you,
Thank you.
sir.
Thank you.
Thank you.